Hi, I'm just leading up from the same question, really. A lot of people, it seems that relapsing remitting is very common. So at which stage does it progress to a progressive MS condition?
We don't know is the simple answer to that, and often recognising that someone's got secondary progressive MS can take a couple of years, actually, because there's no criteria, MRI criteria, like there is to diagnose relapsing remitting MS. And an MRI scan's not, a standard MRI is not helpful in telling if someone's got relapsing or remitting or secondary progressive or primary progressive. They all look the same, often. We often make the diagnosis retrospectively, so when someone's had a year or more where their symptoms have worsened gradually without having an attack. Because people's symptoms can deteriorate if you have a relapse, but if there are no relapses and someone's noticed a progression of their symptoms, that's often how we diagnose secondary progressive MS. What we don't know is, does a switch just flick one day and the MS goes from being relapsing remitting to secondary progressive, or is this a single process that starts right at the beginning as well and only becomes apparent after a certain period of time when, say, a certain number of nerve cells have been lost in the brain?
There's one topic that doesn't seem to be well covered, and that is temperature sensitivity and the mechanics, especially regarding temperature and fatigue.
Yep.
Is there much research done on that or understanding?
The nerve cells that have been damaged with demyelination are working harder than they should do, or than they ordinarily would. And conditions in which they have to work harder than usual, if you're sick, tired, stressed, or hot, will make MS symptoms worse. And that's been recognised actually for, Dr. Louis can probably tell me, over 100 years. Yeah, it's named after a neurologist called Uthoff, which is a physiologist, I think. Anyway, he can clear that up. But the reason that symptoms are often worse after a hot bath or after you've exercised or when you're away on holiday in Fiji is because those nerve cells are having to work harder in the heat. So it comes down to physiology. There's no simple way of treating that.
Another question?
Dr. Brownlee, you talked about the importance of starting treatment from the CIS. How can you make that diagnosis quicker and clearer? I had what now turns out was a CIS, but was told, oh, you've only got one lesion on the spine. It's a virus. And then 10 years later, I'm finally diagnosed with MS.
Could I ask you, did you have a follow-up MRI scan?
No, I didn't, because I was told it was a virus.
Yeah. So, it's always difficult when you see someone with that very first symptom to know, is it going to be a one-off event, or is this the first symptom of MS? And in fact, if your brain scan was, you had a spinal cord and a brain MRI scan probably, you just had the spinal cord. If your brain MRI scan had been normal, then I would have counselled you that your risk of developing MS was 20% or 1 in 5, okay? Obviously, if you've got the symptoms, you're going to have a lesion causing the symptoms, right? So you can't count that. You're interested in other lesions outside the area that's affected. Had you had a brain scan that did show lesions, then with the diagnostic criteria we have today, that we didn't have 10 years ago, I might add, then we may well have made a diagnosis of MS. And certainly, if there were no changes on that initial MRI, or there were some changes but they weren't definitive or conclusive, we may have done an MRI scan 6 months later. And I'm sorry that there was a delay in 10 years for the diagnosis. That's such a common story. And I think there's been a large change in practice as a result of MRI research like this, and I think neurologists are much more proactive now about making a diagnosis.
One last question over here.
Because all your research is based on MRI scans, and you have one when you have an initial event of some sort, then you might have another one because they didn't make the right decision in the first place, like my friend over there. When would you have a next one? Because if you're going to assess people by these MRIs and by the spinal, the other ones, the spinal cord MRIs, how often, I mean, I'm not saying you have them every year,
Aren't you?
Wouldn't you, as
That's
a
a reasonable
person,
suggestion.
want to know what they look like? I know they're expensive.
Fantastic question. Absolutely fantastic question. Now, there's two ways to do MRI scans. You can do them because you've got a diagnostic problem. Someone comes to you with numbness and they've got a problem with their spinal cord, and you need to know what the cause of that is, right? So you do an MRI scan to help you diagnose the problem. But then you can also do MRI scans to help you manage the disorder and make management decisions. And in the United States, for people who are health insured, and across Western Europe, and in Australia, MRI scans are a routine part of people's care. Okay, so you said you wouldn't have one every year, but actually a lot of people with MS living in Australia who are taking disease-modifying treatments will be having an MRI scan every year. And in fact, I had dinner with a friend who works in Sydney, and she was saying some neurologists in Sydney do an MRI scan every 6 months for the first 3 years of treatment. Now, where I work in the NHS in the UK, and here in New Zealand, there's a resource issue for that, as you say. And when I was a registrar at the Auckland Hospital, at one point there was a 9-month waiting list for MRI scans. Now that situation's now much better, I gather, and it's been sorted out. But when you've got someone who is in front of you with an acute problem like optic neuritis or numb legs, or someone that's on cancer chemotherapy, or someone that's got a bone and joint infection, then you have to prioritise the scans. Now, increasingly, neurologists are making treatment decisions based on what the MRI scan shows. So you're on Avonex or an interferon and you're going okay, you've been on it for 9 months, you've not had any attacks, but your MRI scan shows 3 or 4 new lesions. A lot of neurologists around the world are making treatment decisions based on what the MRI scan shows. We think that's a good idea. It sort of makes sense, doesn't it? You don't want lesions on the brain. If there are new lesions forming, you want to be on something a bit stronger. I think, though, that what this research shows is that that's not that straightforward, and that just because you've got 3 or 4 new lesions doesn't necessarily mean that your clinical state, your condition will be any different in 5, 10 or 15 years' time. However, that's what we've got to use, and that's what people use. So that was a roundabout answer, but I think increasingly in the future we're going to be doing more and more scans, and certainly people taking natalizumab or Tysabri, which Dr. Willoughby is going to discuss further, and people taking alemtuzumab, one of the medicine that Dr. Brownlee described, that you just give an infusion or 2 infusions over 2 years, and then you don't give any more treatment. You just follow them with MRI scans. That's absolutely required ongoing monitoring.
Thank you, Wallace. We've been really privileged this morning to hear a very bright young doctor from New Zealand who is working in the field in which we're all interested. What impressed me most was the way in which he was able to explain very complex things so simply and so in such a straightforward manner. So Wallace, thank you very, very much for your address. You can spoil his lunch by asking him questions directly. Lunch is now served, and we suggest that you get lunch and bring it back to your tables. But before doing so, would you please show your appreciation for Wallace?